Hey, good morning. Welcome, everyone. Thank you for coming to Pediatric Grand Rounds Primary Children's Hospital and everyone joining us online. I am Miguel Canaco, your pediatric hospitalist and course director, and today is the first one of the academic year, annual Department of Pediatrics edition. And I'm just going to say some thank yous to a lot of people. Thank you, everyone who gave feedback in the evaluations, because we use that for all the future years. We love hearing from you. Thank you to our AV techs. Um, the ones here are Jeff and Ethan, and then in Lehigh we have Tim. And thanks so much to our coordinator Julie and our nurse planner Christy and Nitzia, our point person there in Lehigh, and all the support each year from Primary Children's Hospital, Primary Children's Foundation, who helped us establish a new annual behavioral health lecture. That'll be December 4th. University of Utah, there's departments of pediatrics and surgery and pathology and others, medical staff office, Intermountain IPCE, and Director Janelle Murray. It's a huge collaboration, and I'm really grateful. I'm really grateful to so many people who help it happen. Today's claim credit code is 40527, and the easiest way is to text that in. The online questions, look for live chat. That's how you put those in, and just type it in as soon as you think of your question, because there is a 10-second delay from when I'm saying to when you're hearing it. So just type it in right when you think of it. And for everyone in here, you just raise your hand at the end. The overhead mics will pick you up. You don't have to repeat the questions. And so, okay, once per year, we begin with an Indigenous land acknowledgement. So we acknowledge that this land, which is named for the Ute tribe, is the traditional and ancestral homeland of the Shoshone, Paiute, Goshute, and Ute tribes. The University of Utah recognizes and respects the enduring relationship between many Indigenous peoples and their traditional homelands. And we respect the sovereign relationship between the tribes, states, and federal government. And we affirm the University of Utah's commitment to partnership with Native nations and urban Indian communities through research, education, community outreach activities. Today, approximately 60,000 American Indian and Alaska Native peoples live in Utah. Safety moment time. So at one of our campuses, we had a very young patient we were sending home to very far away who had complex needs, but also who we felt was maybe at risk for being over-medicalized. And so during the stay, the family found a pediatrician they trusted because this doctor was able to communicate quickly in their town with the local relevant subspecialist. And so at the family's request, we arranged hospitalist to pediatrician phone call at a time convenient for that pediatrician. And having the same electronic health record, this doctor had been following along in the notes as soon as they got the appointment call. And so already knew about it, shared the same concerns, not only for this patient, but other children in the family. And so together we discussed our overall strategy for the next year of the kids' lives to, keep them healthier and protect them from unnecessary tests or procedures. And so I thought it was a really great communication moment. If you notice someone using a zero harm safety error prevention technique, then you can nominate them for safety award. And they are the the basic safety communication techniques. That's what we use. Most important one as psychological safety and speaking up. Okay, now the introduction for our speaker. Dr. Angelo Giardino is the Wilma T. Gibson Presidential Professor and Chair of Department of Pediatrics at University of Utah, and he is Chief Medical Officer at Intermountain Children's Health. Thanks for teaching us today.
Thank you, Miguel. In terms of gratitude, when Joyce was the CME director, and then she said she was going to step down, I think we all were a little concerned, like, what's going to happen? And then I think, you stepped up and you've done a great job. And we're very appreciative of how you keep us organized, how you make sure that you tie in all of the speakers to the needs assessment. So thanks for the work that you and your team do. Thanks. Okay. This is the 8th time now I've started off the academic year with this September Grand Rounds. And I wanted to really share with you a concern that I have. And this has been on my to-do list for a long time. So after 8 years, I think I need to put it out there. And it really relates to referral relationships between our pediatric subspecialist and our pediatric primary care community, and also the family medicine folks and the advanced practice providers in the community that refer to us. And I also want to talk a little bit about how consulting services and attending services work together, and how we message while that we're working together, and how that's perceived by the families. So I don't have any relationships to disclose. This is the objectives, which is what I just said. So many of you know I like to talk a little bit about history when we're dealing with a problem, because there's nothing new under the sun, and if we're talking about something now, it probably was a problem a while ago. So in 1970, at the National Association of Children's Hospitals and Related Institutions, that's NACRI, that was the progenitor to CHA, which is what the company's called now. There was this great talk by Dr. Hamilton, who was the president of the American Hospital Association, and this is what he said in 1970. Today, we seem to be facing some of the greatest crises ever, which threaten the existence of the voluntary hospital system, increasing costs, Medicare, Medicaid. Remember, Medicare and Medicaid were only 5 years old in 1970. Lyndon Johnson signed that law into being in 1965. He flew to Missouri and did it with President Harry Truman at his side, because Harry Truman wanted to have Medicare, Medicaid when he was the president. So government pressure to revamp the system, plan between and among rather than within institutions. So all this network development, and then the challenge of and cost of computers. So I think if you just kind of updated that now to 25, you would probably say IT and EMR. And thinking about Saturday, I would say epic. So, so we really are in healthcare dealing with similar issues. We just have different challenges depending on the time period where we're carrying the baton in the relay race. So I have restrained optimism that we're going to get through this really tough period, because we're going to stick to our values. We're going to have a plan. We're going to work together, and we're going to do what we do best, which is take care of children. Okay, so just a little bit more history. This is this memo that I like to share with people. So this is Joe Horton's memo to the president of the hospital at that time in 1987. He was really highlighting that he thought primary children should adopt this motto, the child first and always, from the Hospital for Sick Children in London. And of course, as you know, we did, and it's emblazoned in all these walls that we have. And there was also another quote in there. It's many things we need can wait, the child cannot. I like that sense of urgency. I think that's a motto that we should adopt as well. Okay, and then I was hired by Loris Betts. So I don't know if many of you probably remember Dr. Betts. And then he was the senior vice president and dean, and then he retired. And then in 2017, he came back for a year, and during that year, he hired me. So I have a great deal of respect for Dr. Betts. And this was his quote. It was from 2008. And as you know, the University of Utah is uniformly recognized across the healthcare industry of being very focused on patient experience. And it's because of this quote from Dr. Betts in 2008. Medical care can only be great if the patient thinks it is. And as much as I respect Dr. Betts, I would just like to modify that just a little. So I think the care is great if the patient and family thinks it's great. But I also think the attending service has to think it's great. I think the consulting service has to think it's great. And I think the referring healthcare provider or the practice has to think it's great. I think this is a collaborative effort, and this is a fairly small community. We frankly know each other. So I think we have to broaden that a little bit, and we have to come up with a systematic, data-driven way of working together to winnow out any variation in how excellent or how great the care is. And I will show you the care is very, very good. I would even say it's great a lot of the time, but sometimes it isn't. So that's variation. And we are really good at Intermountain Primary Children's and at the University of Utah in trying to squeeze unnecessary variation out of a system. Okay, so of course, my solution to this is going to be quality improvement, and I really value this statement from Maya Angelou that you should do the best you can until you know better. Then when you know better, you should do better. To me, that is quality improvement, and that's what we do every day here And I want to imbue this discussion of referral relationships and how the attending services and the consulting services work together with this idea that we're going to do as good as we can, and then we're going to learn how to do it better, and then we're going to hardwire how to do it better, and we're going to do it in a data-driven way. We're going to measure it. So in business school, they teach you if you don't measure it, you're not managing it. And that's true most of the time. So I don't want to overdo that. But you do have to have a systematic way of measuring things. And then that measurement has to be shared back to the people at the front line who are doing the work. It's really not helpful if I'm the only person that has seen the data. Because, I bump into people at the coffee maker all the time, but I'm not doing that systematically. So we have to have this data-driven, stakeholder, inclusive way of doing that. And then I had the privilege of being at a retreat in the early 2000s where Lee Carter, who was the chairman of the board of Cincinnati Children's, spoke. And his challenge to Cincinnati Children's, which is truly one of the iconic children's hospitals in the United States and frankly the world, was that they wanted to be the best at getting better. And that has been a model I have tried to have in my life, and I hope we're imbuing that here. We're going to be great at getting better. We're not always going to get it right, but we're going to always want to get it better. And I think if we have this as a driving force, we'll do really well. So the Institute of Medicine, now called the National Academy of Medicine, has defined what quality is. And it's the degree to which healthcare services, and think about that as healthcare services, the things we do and the way we do them for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And you always need that last little bit there because you always have to do this in a data-driven, evidence-based way. And as we know as scientists, and not everybody understands this, but we're scientists, so we know facts grow and develop. Evidence grows and develops. So we will change our mind as we learn how to do things better. So we're always going to make this data-driven. Okay, so, I've said this to many of you before, but if we want to make a quantum improvement in children's health, and again, remember, we're Intermountain Children's Health, we're part of the University of Utah, and we're primarily responsible for how children are served. We're going to have to improve faster on a larger scale and with greater impact. And that's what's going to allow us to build this nation's model healthcare system for children that Intermountain has pledged. That's what Children's Health says. We are trying to develop one of the model systems for the United States. And if we're going to do that, we're going to have to really step up and do this in a data-driven, systematic way that's very inclusive. Okay, so some of you know Chris Stella. He is the division chief for general pediatrics at Denver at Colorado Children's. And he and his team put this paper out in 2017, and he had a call to action. So I knew Chris when he was a resident. So the pediatric primary care specialist interface, a call to action. And I would just add the attending service and consulting service interface. And he kind of went through this very good paper where on the left-hand side, he talked about the key issues, which were access, communication, coordination, and including the family. I'm going to focus on communication and coordination. And there's best practices, and he talked a little bit about what was current then. There's implementation strategies, and then there's challenges. And the point here, and we'll keep coming back to this, is one, there's a literature that we can refer to. And two, a lot of the communication issues really try to work through how are we sharing information back and forth in a way that makes sense to the people that are getting them. So the attending service, the consulting service, the family, the referring pediatrician, the subspecialist pediatrician or surgeon, and the family. And then in terms of coordination, this is where our system comes in. So, spoiler alert, the glue that holds almost all of this together is that you have to have care coordination as a function on teams that deal with very complicated people. So we're very blessed here in that we work with Intermountain Health. They have a really robust care coordination system. And we just have to be good about roping that in and tying that in and hardwiring that in so that the very busy clinicians have the support of the care coordination function so that we can stay coordinated. Okay, so this is the ideal model, right? everybody's talking to each other. The patient and family are in the center. I've used this diagram before. The PCP is talking to the people on the outpatient side, and then when they go to the emergency room, they're all talking to everybody. And then if the person gets hospitalized, the hospitalist is talking to everybody. And then there's like, the aftercare, and then the community, of course, because we believe in multi-sector work, right? So kids' health is not just health care. It's education and social services and informed law enforcement and good courts and legislate, it's the whole community. So you could also modify this a little bit. It really is if everybody's talking together in healthcare. So the PCP and the subspecialist should be talking. If there's another subspecialist, they should be talking. If the person gets admitted, the inpatient attending needs to know what everybody's been doing. And then if the inpatient attending needs a consult, the consultant should be talking to everybody. Nobody should be independently talking to the patient and family in my world. So the inpatient attending service should not discover that the consultant would like to do X, Y, and Z from the family. So I'm going to declare a never event. So in patient safety, there's these concepts of never event, right? So like you should never transfuse the wrong blood type. Like that in an American hospital, there should be systems in place where it just would not happen that you could hang the wrong blood. That's a never event. I think a never event would be a consultant telling the family something that they've not discussed with the attending service first. And the solution to that is that if you're the consultant and you're verbalizing something and you don't have a memory of telling that to the attending, you shouldn't say it. Like that's how you're never going to do that. Like if you did not have the conversation with the attending service, then you shouldn't say what you're going to say. Because you can just go outside the room and, I've been on the floor. The attending service is right there. It's not like they're somewhere else. Like they're here. So I just use that as an example. And I will say a lot of times this happens perfectly. So we have great consultants. We have great subspecialists who support the teams. And there's a lot of conversation. And we have a unified, coherent message. That happens a lot. But when it doesn't, it's really difficult for the families because they get stuck. And the one thing families have told me is they hate being the information shuttle between the services here. They just hate that. And you know what they say to me? They say, "Do you people work together?" Oh, so, ugh. Now, that's anecdotal, okay? So I don't have a systematic way of knowing how often that's happening. So I want to elevate this conversation from my anecdotal experience to something that we're going to manage. But again, we want to be really clear. The attending service is the attending of record. In United States law, the attending is the one that is making the decisions with the family. And the consultant is helping. And I am not confused by that. And I just want to make sure that that is really understood. The attending service is the physician of record. And everybody that's asked to help is helping the family, of course, but they're helping the attending service decide what to do with the family. So we need to kind of hardwire that because, we have to winnow that out because the families really don't like that. And in like turn, when folks that own and run practices in the community, give us the privilege of helping them serve a patient, we need to get back to them. And we need to figure out, like, this is not an enormous community. I've worked in some places that are enormous, that like there's millions and millions and millions of people who live there. This is a very manageable community. So we know who the providers are. So we have to figure out how they want their information, how they want to consume it. And if somebody has privileged us by asking us to help them with a patient and we're the subspecialists, then we have to figure out how to get information back to them. And some of the primary care providers, again, this often works well. And the primary care providers speak really in laudatory terms about the pediatric subspecialists here. They really do. They think you're the cat's meow. I mean, you're just great. But every once in a while, I will see somebody. And sometimes, because this is a small community, I see them like at Harmon's. And it's like, I didn't even know that my patient was coming to see you. I'm like, okay. So like we can avoid that. We have technology, we have approaches. So I would love for primary care providers to feel like they will always know if we're helping them take care of a patient because technically they're the attending service. So I'll keep coming back to that. Okay, so these are my guiding principles. I shared these in May. So I'm, in this restrained optimism where we're going to lean into our values and we're going to be the people that we are, and we're going to live in a dignified way, and we're not going to feel beaten down and embattled. So we're going to have guiding principles that get us through the day, the week, the month. So my ABCs are advance excellence. So if we're doing something, if we're investing our time and effort, it better be to advance excellence. We should never want to do something to just get by or be mediocre or be adequate. That is not in our DNA. Intermountain Primary Children's Hospital is not about being adequate. We are about being excellent. The University of Utah is about being excellent. We are not about being adequate or mediocre or regressing to the mean. That's not us. So we're going to always focus on advancing excellence. Now, there's feasibility to that, and there's a sequence, and you can't have everything you want the day you ask for it. I get that. But we're always going to be driving towards the best. We're going to always build bridges. It is not good for us to be snarky. It's not good for us to be polarizing. It's not good for us to put people off. So we're going to call people in rather than call people out. So in the advocacy world, we're really, really embracing this model of calling people in rather than calling them out. It feels great sometimes to call somebody out because you can really dress them down. You can just feel really powerful for 2 seconds. Then you realize I have just destroyed a relationship that's going to take me 10 years to repair. And frankly, that wasn't me. I don't want to be that person. I want to be the person who's finding the one beginning of common ground that we can build off of. And that's what we're going to be about. And then finally, we're always going to cultivate teaching and learning because that's us. We're academic. So in my little 2x2 table, when you know something about the topic and the other person knows something about the topic, that's shared knowledge and you have a great conversation. When you know about the topic, but the other person doesn't know, then that's your teaching opportunity. You should use your facilitated learning and you should get information out to them. And then if they know more than you should be quiet and polite and learn. So that's a learning opportunity. And then there's things that we don't know, none of them knows, and then that's when we should decide how to learn. Okay, so that was the preamble. That's us. We're going to get better at how we manage referrals, and we're going to get better as a team in how the consulting attending services work together. There's actually a literature, and I won't belabor this because this is all going to be available. And when I get to the end of the talk and I do my call to action and ask you to help, you're going to have to read all this. So, but just to cut to the quick, this goes back to the turn of the century. So Chris Forrest is a great guy. He was actually one of my chief residents somewhere in that process, and he's a really good health services researcher. So he did some work on why people in pediatrics ask for subspecialty consults, and you can kind of see the referrals are usually because people want some advice on a diagnosis, right? So that's a good thing. That sounds like it makes sense. In pediatrics, a lot of referrals go to surgical services. So we have a great relationship with our pediatric surgical colleagues and all the different departments they're organized in. So we'll want to pull them into this. And a lot of times they're the consultants. So we'll certainly want to share our view of what a never event is. And we'll really invite them never to say something to the family if they haven't talked to the attending service first. We'll do that in a collaborative way. And then obviously about 30% go to the medical subspecialists. And then there's other folks, dietitians, and then behavioral health. Now this was in the early 2000s. So I think these numbers probably changed a little bit. And almost everybody that's involved in referrals and consultations wants to stay involved. The PCP wants to be involved. Okay. And so that the physicians request that consultation shared management in 75% of the cases. So the PCPs usually want to stay involved, and the subspecialists usually want to stay involved, and that's a good thing. That's how we're going to be able to really go down this road of co-management. And there's going to be really good best practices that have emerged over the last 30 years of how primary care and specialties, how attending services and consultants can work together and stay involved. Now, like any good academic, if you did a good paper in 1999, you keep repeating it and you just give an update. So Chris did this. So in 2024, this is the new one. So this repeated cross-sectional study of annual subspecialists examined 3 complementary data sources. So it's really gotten more sophisticated, and they draw from disparate sources. So they get a really good assessment of people asking for outpatient consultations from medical subspecialists. So in general, 8.6% of Medicaid beneficiaries, 10.4% of commercial insurance, and 21% of people that get their primary care in a sophisticated academic system like ours get consultations. So that's why you hear, whenever you look at these reports, they say between 10 and 20% of kids get a subspecialty visit, and this is the data that this comes from. So that's a pretty big range, 10 to 20, but it's about 20. So just putting my other hat on in terms of children's health, that means 80% of kids don't need subspecialists. So the vast majority of children in America, and the vast majority of children in Utah, and the vast majority of children in the Intermountain West do not need subspecialty care. So primary care is carrying that burden for 1 million kids in Utah. Like, the primary care people see 1 million people every year, and then we're seeing 20%. So just, we have a lot of respect for primary care and the burden that they carry. Okay, so in this paper, he talked a lot about the top 3 reasons. And in this talk, I'm going to talk about 3 subspecialties because we have some data on them. So in child neurology, you can see the most common reasons are seizure, developmental delay, and migraines. In gastroenterology, it's constipation, gastroesophageal reflux, and feeding problems. This is national. And then in pediatric infectious disease, TB was really big, and then fever. I thought for ID, it would be, what does the Red Book say? I thought that would be, so, because that's what we get. So I just say this to show there's a lot of opportunity here for these shared management concepts, right? This co-management, because these are fairly routine problems that probably have some complexity if they're asking for a subspecialty, but the primary care provider and the subspecialists want to stay involved and work together. Okay, and then this is a paper that talks about hospitalizations, and hospitalizations are a little bit complicated. So between 2009 and 2019, there was a decrease in inpatient hospitalizations, but a difference in the distribution. And some of that's because a lot of care is now done in the outpatient area. But the interesting thing for us is that distribution is the rural hospitals and the urban non-teaching hospitals are seeing less kids, and the children's hospitals and the urban academic centers are seeing more kids. And that's because a lot of programs are getting rid of pediatric departments, but the academic centers are keeping pediatric departments. And of course, the children's hospitals are totally focused. So for us, the part of the data trend is that we're seeing more and more and more kids. And then you can kind of see on that graph, the orange is people with disability diagnoses, and then there's the mental health diagnoses. And then at that top blue line are people with complex medical conditions. Well, that makes sense, right? And again, that's likely who's coming to children's hospitals. So our need to get really good at inpatient care is growing, and we have to have more capacity, and we have to have great ways of having the care connected back to primary care. Okay, so the literature has these great examples, and this is one that I'm particularly fond of. It came out in 2014, and essentially they said that the requests for subspecialty services are increasing, and we experience that. There's more kids. Kids have a lot of different medical conditions. Kids are surviving longer. So it's not surprising that we need more subspecialists. But I think the bottom part is what I'm interested in. Communication is important to good care was a question. for a survey they did. So 98% of the PCPs and the subspecialists agree. So this is gold. If you're doing quality improvement work and 98% of the people that you're going to invite to work on it think it's a good thing, then I think people will come to the meeting. 60% said that there's barriers, and 63% of the primary care providers and 35% of the specialists are dissatisfied with the current referral process. So here's the opportunity. So there's good literature that supports what we want to do. Okay, and then there's more literature, and what this is just trying to say is that the communication could be a lot better. So the subspecialists want more information from the referral source. And the primary care providers want more information from the subspecialists when they're done. And the numbers change from time to time. But the key point is the opportunity is there. The subspecialists need more information from the primary care provider, and the primary care providers want stuff from the subspecialists. And I think we can address this as well. And then this was a really good report in the Millbag Quarterly. And again, it just highlighted the fact that sometimes the referrals come or the consultation is requested without really good preparatory information. So we're going to have systems that get that for us. And then when the referral's done, the subspecialist needs to get some information back to the primary care provider or to the attending service. And everybody has different ways that they like to consume information. So our system has to be adaptable and nimble and agile, because it's not that everybody wants to get some message through the electronic medical record. Now, that should always be there and available, but some of the people that we work with really want a phone call. And we have to see if we can do that. And if we can, how are we going to facilitate that so it's easy to do? Okay, so we're back to Chris's call to action. So what about our system? So I gave you this, my view, advance excellence, build bridges, and, let's seek to understand and educate each other. And then I gave you some of the data, but how's our system working? And what I would say here is that we have some evidence that it's working well. We have some evidence that we have some variation, and we don't have much current evidence. So this is where we really need to have this systematic, data-driven, focused effort so that we are managing this very important set of relationships. And the only way we're going to do that is if we have a kind of a way of measuring that's meaningful, that we all agree, and then that we get the information. And then the information has to get deep into the organization. It can't just be a few leaders know this. Okay, so what about when someone has a question? Well, there are so many ways to reach the pediatric subspecialist in our health system that it's dizzying. So I'm going to share some of this data. Like the amount of data harmonization and kind of conceptual discussions that had to happen so that we could figure out how many calls were coming in was amazing. So we're going to have to get more systematic. Okay, so from September 25th to October 28th in 2023, we asked the ID team to literally keep track of every time people were getting in touch with them. And so that's on the left-hand side, the manual tracking. And you can kind of see how this stuff came in. SmartWeb got in touch with people. The pediatric access line, that's this phone number that primary care providers can call this line. And they say if it's urgent, they want to call back in 30 minutes, or if it can, wait till the end of the day or the next day. So the PALS line, and then direct. Okay, so some people are giving their cell phone numbers out. You're on your own if you do that. Because I don't know how to manage. I think that's lovely. And if you have a certain way you live your life and you can deal with that, that's great. The problem with that is that how do you I'm sure you don't forward your phone number to the person on call. So you're going to be on call 24/7, 365. So I don't encourage that. Then there's the transfer center, and then there's other. And then when you move over to the pie chart on the right, this is the time of day. So 60% of them came during business hours. And hopefully we've assigned somebody to be responsible. But that person usually is doing something else. Just like the day in the life of a pediatric subspecialist. You probably have a service, you probably have a few students and a resident, and then you have a couple meetings. And then if the meeting's with me, you probably think you should make the meeting. So like you have a very busy day, and you're getting a lot of calls, apparently. And then after hours, 36%, and then overnight, of course, some things come up. Now, gastroenterology, Steve Guthrie and his team, they gave us data from 10/27 to 11/3 in 2023, and like they have all these data entry points. So the PALS line, PAS, which I'm not even sure what that is, but that's a really big one. Smart Web, the Transfer Center, this thing called P2P. Now, it doesn't look like they're giving their cell phones out, or at least they didn't own up to it. And then on the manual tracking, you can see there's 21% after hours. They get a lot overnight. The unreported, I'm pretty sure, is probably a lot during business hours. So that's a very busy day. And then neurology, and neurology are very special people. So like they only did the manual tracking. They didn't say what time of the day they got it. So they did theirs for 1 week, 9/15 to 9/22. So you can kind of see they have all these channels in. So my point in sharing this is it's really good to have data. It's really good because it gives you the current state. It's really complicated. There's a lot of ways to get in to the subspecialist. And if we're going to get good at this, we have to understand the burden that is to the subspecialist. We're going to need to understand why are people using all these systems, because they're using these systems likely because that's how they do their workflow. So we'll have to do some harmonization. Now, all of this was put into some big statistical model, and Spencer Hinckley, who's our data analyst in the Department of Pediatrics, did some really complicated stuff. So he actually did some like predictions based on this using that data I just showed you, and then a whole years of data that he could get from a data repository. And this, not to get too far into this, because the gray is the numbers that we absolutely counted ourselves, and then this hatched part is what we think based on some data harmonization, what it's likely to be. So essentially, gastroenterology is getting 220 calls a month pretty consistently from outside people. Neurology is getting 335. ID is getting 137. You can see the go there. So that's one reality. That's a lot of calls, because these are not just like, hello, how are you? This is, I have a patient, there's a little presentation, then there's data, then there's like real medical thinking. And the reason why they're calling is because it's a remember, the person calling you is a physician. So they've thought this through. So this is complicated. Like they have a question now that's a very sophisticated question. Okay, so it's more complicated than that, because I see Steve is probably about to have a stroke, because it's not just the 220 calls that his people have to deal with. Steve's people have to deal with 3,671 contacts, and in a month, because they have patients that they're managing, and people are contacting them all the time about patients that are on their service right now, about patients that they're taking care of with somebody else. And there's just a lot of ways for that data to come in. So if you just look at that bottom table there, for gastroenterology, they get 3,671 contacts. Infectious disease gets 815, and then neurology gets 4,383. And then that bar chart there on the lower right, that shows that for neurology, I think it's 89% are patients that are known to them. So they're getting calls about on 11% of patients that they've never seen. Infectious disease, it's 85, so they're getting calls on 15%. And then Steve's team, 18% of the people they're getting calls on, they've never seen. They don't know them. They're literally out there on a limb trying to do a good job, but just based on a contact. And then 82% are people that they know. So I share all this to say this is really complicated. There's a lot of information flow, and we've got to get good at this, because this is fatiguing. This is wearing people out, because in addition to all this, everybody's rounding. They have patients in front of them. They're doing outpatient visits. They're doing an inpatient consultation. Some of the folks do procedures. There's meetings. They're writing papers. They're doing research projects. So life's complicated. We can, I think, get our hands around this and then set up systems that manage it. Okay. Now, what about the referral volumes? This is off the charts. So this is 2022 to 2024, and I thank Justin and his team for getting this. But like in cardiology, I think that's 459. Yeah. So that's monthly. Look at gastroenterology. Oh my God. They're at like what 600. So and then neurology 437. So like we have a lot of patients that we need to help our community take care of. And this is something that we've been ramping up for. We're recruiting. Intermountain Primary Children's has been helping us recruit people. So we're trying to meet this need. We're doing a decent job. We could do better, and we want more people. We need more space. But like, if you just go a little bit down there to gastroenterology, so it takes about 25 days for the referral to mature, and then in about 55 days, we're going to see that person on average. And then if you go down to neurology, it takes 29 days for that referral to mature, and we're going to see them in about 76 days. So we would like that to get better. But this is after a lot of work. And let me just show you this. So we see 16,000 people a month. And every month we see an additional 180 people. Like this, it's just growing. It's like, I don't know what the slope is, but it's upward. And then this is like all the divisions, like everybody's going up. And then that blue line in the middle that's like, going into orbit, that's behavioral health. So we have a lot of work to do, and it's just going to get more complicated. Okay, so now I just want to share just a little bit of data about a survey we did in 2021 where we asked our community providers who were referring people in, how do they think about so we had 93 validated responses. This was done in March of 21. And the question was, how would you rate the primary children's hospital or specialty clinic's communication to you in 2020? And look, it's great. Like 21% thought it was excellent. 30% thought it was very good. 34% was good. There was only 14% that thought it was fair. So I think this is a decent starting point, and we've got to get better, and we could probably get better and better because remember the guiding principles, advance excellence. So I think we want more and more people in excellent. So then we asked them, would you say the communication received from primary children's was better or worse, about the same? So look, 67% thought it was about the same. 31% thought it was better. So like, we are doing a good job. Like, I just want to make sure the message that should go forward from this grand rounds is you are all working hard. You're all doing a great job. Our community is doing a great job, but we could do better. Okay, in what specific ways was the communication received about the patients better? So said that they received more patient notes and reports. Two commented about e-consults. And then how was it worse? Two people said, I often had to request notes from the specialist. And then another person had extreme difficulty reaching the subspecialist for very medically complex patients. How could the communication received about your patients be improved? 46 comments came in. Again, this was in 2021, right? So talking about care in 20. So there's a lot about Icentra in here. But I just share this to say there is a baseline, and we should probably do this survey regularly. We should commit to really having this, and everybody should know it. And then it should get stratified down to the programs and the divisions. During 2020, what was the biggest challenge you encountered? 68 commented. So the number one challenge was related to scheduling the clinic appointments, and I just showed you that. The second 10 people commented on communication. The third challenge was access to the specialist, and the fourth was referral issues and lack of response. What specific changes would make it easier? So 59 comments. One recommended changes in how the referral process happened, and others wanted like or digital opportunities. And then 7 comments were about the follow-up. And then, do you recall receiving communication? So 48% said they don't remember, 41% said they did. And then what was the specific communication? So 28%, that's the bar chart, said they got notes through the medical record. 20% said they got some individual emails. I'm not sure what the webinar is. I'm hoping we're not talking about patients at a webinar. So you can kind of see those other things. So again, we have some data. We just have to get better at doing this. In what specific way was the communication received about your patients better? I credit the improvement to our care coordinator. So these are the people at the primary care provider who actually are doing the follow-up. The clinic seemed more proactive. And then I received more direct notes from the specialist that saw my patients. So that's all really good. And how could it be improved? This one clinic said, like, could our PAs and NPs in our clinic be able to talk to you about patients and not get into all the HIPAA stuff? Ask the collect who the PCP is when they're getting service, and then make sure that we get a message about it. And then this is the comment that I get at Harmon's. I still discover by accident that a patient of mine has been seen by a specialist and I didn't know. And then communication pushed to the PCP rather than expecting us to find it when we go to the power chart. So like this is where everybody has a different way of consuming. Some people love getting the stuff through the medical record because that's how their workflow is. Other people want a contact specific to them. And then what specific changes? So I've really enjoyed the willingness of specialists to come out to Utah County and give presentations on primary care topics. I think this has made a big difference. Okay, if we send a patient to the ER and the doctor there disagrees with what we think, and that happens, right? That's why you're sending them somewhere, because the person you're sending them to has some expertise, and disagrees with what we think the best course is, please call us. Now, that's what's really important. I think the primary care provider wants to be respected. They want to know what your thought process is. And then in all candor, they're the ones that have to then explain it to the family. So the next morning, the family's going to be in their office, and if they know what the rationale is, they can kind of support that. And then in the interest of maintaining a medical home, it'd be nice to get something other than, through the medical record. Okay, so we have to also talk about the patient and family, right? So in terms of healthcare quality and crossing the quality chasm, involving the families is just absolutely essential. So what are the families saying? Well, the good news is the families love getting care here. They really do. This is from last week. We send this out in the newsletter. So the doctor is knowledgeable and took her time with us, treated my son with care and addressed our concerns. Friendly, educated, easy to understand. She sent a follow-up email and a hospital letter right away. We've been seeing Dr. Name for years. She knows our family history, works well with the other doctors that our child sees. I feel confident that all my child issues are being addressed and the doctors are coordinating with each other. And I'm going to read these because I think it's important for everyone to hear. We do a great job most of the time. The doctor was worth waiting to meet. She was knowledgeable and good at explaining. Doctor has been very attentive, helpful, great to have handle my child. She is friendly and very knowledgeable. We highly recommend her. I mean, those are beautiful comments, and those are heartfelt because they actually, some of these actually, get the person's name and they spell it right. Okay, then last month, absolutely loved the doctor who was so easy to talk with and listened. The doctor's name is worth navigating Salt Lake City traffic. Okay, live in Houston and you will see what traffic is. He asks thorough questions about my son's seizures and he takes the time to examine him well. My son is in good hands. So-and-so is amazing. She was very knowledgeable about my son's issues and took the time to explain everything. What an amazing man. He cares and listens. Doctor is kind, approachable, knowledgeable, and I can trust him. He explained everything at my level, at my child's level, and helped me to make a plan to help her feel better. Doctor's name is very kind and personable. She really took time to explain things. She really connected with my son and seemed to really care about him as a person and his health. I mean, these are beautiful comments, and this is what we're about. This is our DNA. So I want to make sure everyone knows, a lot of times you do a great job and the families really respond to that. There are some challenges, of course. So there were too many players, too many teams, which created poor communication at times. The teams never rounded in our room or invited us to step out. So we were shocked to learn that they had been rounding every day, twice. The individual physicians that would take time to step in and share were deeply appreciated. And then this one, I asked for fluids. The attending pushed on my daughter's leg and said, oh yeah, she has delayed capillary refill and her lips are really dried. We can probably do a liter of LR. The resident was not in the room at the time. When she came back in, I asked her about the fluid. She told me she didn't think my daughter needed them. I confirmed the attending had agreed. So the families hate being the information shuttle. I confirmed the attending had agreed that she was dehydrated and she would talk to him and left. I quickly realized that the attending and the residents did not seem to be on the same page. So these are things that we can get better at. And then I was not listened to. I don't know where the communication breakdown occurred, but it was very frustrating. Also, too many doctors involved and anyone doing a different care plan. Well, if the attending service and the consulting service are talking, then the care plan is going to be more unified. Okay, so the solution, and the solution to everything is quality improvement. So we're going to be the best at getting better. We're going to learn from Lee Carter. We are going to learn from him because he was a great leader. He was a wonderful man. And he is, he and Jimmy Anderson at Cincinnati Children's are singularly responsible for putting that institution into orbit. And they're a great place, and the nation benefits from them. Okay, so you know all my views on this. So a Lewin model. So we have to unfreeze the system, then study it while it's unfrozen. Then we have to make some changes. This is PDSA cycles. And then once we get good, then we want to refreeze it. So it's pretty simple. It has to be data driven, right? So data is the cornerstone of quality improvement. So a systematic process where we get good data, we agree on the metrics. But that is important because it separates what we think is happening from what's actually happening. So that's really important. We have to know what problem we're solving for, but we also need to know what the data is, because how is it working? It gets a baseline, and then from that baseline, we can see if we get better or worse. And then it allows for comparisons and benchmarking. Again, this is us. I mean, I'm asking you to adopt these: advance excellence, build bridges, cultivate teaching and learning. And then we're at Intermountain. Oh my God. One of the reasons why I wanted to get hired here was because Intermountain is iconic. I was a devotee of Brent James. What Intermountain and Brent James did for the nation's health is remarkable. So we have that legacy in our blood. So, we establish a team, we describe a problem, contain the problem, and we have the whole thing here. So we're going to need people to work on this. And we are now having a technical difficulty. So the next slide talks about, there's different ways of doing this, right? So, have you ever heard the expression an A3? So A3 is the very formal document that when we commission a quality improvement effort at Intermountain that we follow. So there's a document. So if we form a team, we're going to need to do an A3. And the beauty of the A3 is that it's very stylized. And, if you've done quality improvement here, you've worked on one of these right here. Yep. Yep. Go ahead. Okay. So, my suggestion would be we want to kind of do this in a really formal way. And this is what the A3 looks like. And then we'll do all our tools. And all of you, I'm looking at everybody. Just about everybody in here has done ATP. So you all know this, but we're going to do a process map. We're going to do our fishbone and look at cause and effect. And I didn't fill this in because it should be driven by the people that are on the team, what's on here. And then we'll do our key drivers, and we love key drivers. And then we'll figure out and prioritize and resource these, align them with all the other goals. And then we've got these recommendations. So I would say we should really take this report seriously. They make a lot of good suggestions. We'll align this with what we're doing with the care process teams. And, we have the ability to do this. So who will respond to this challenge? So I'm really going to ask everybody who's in leadership, and then everybody who feels responsible for a program, and then everybody at the front line to think about, is working on the relationship between primary care and our pediatric subspecialists important to you? And do you want to help make it better? And then I'll need you to kind of think about how to volunteer to help on that. And we'll come up with a way to do that at the large institutional level, which would cascade down to the divisions, which would then cascade down to the programs. And we'll do this in a formal way. And my commitment is that if we really do respond to this, next year's September first grand rounds, I will share this podium with the people that worked on this project, because I want to hold ourselves accountable to each other and then to our community. And I want to show them how we collected the data, how we adopted some best practices, and how we showed that we got better. Because we're already really good. I mean, I showed you the data. We're already really good, but we could probably pursue excellence. So I'll share this podium, and I probably won't say much next year because there'll be so many people that need to say something. So will you help me launch the effort? So that's the call to action. We can be better about this very important element to really excellent children's health care, which is the primary care providers and the pediatric subspecialists share information and work together and do co-management, and attending services and consulting services are on the same page, and they message a coherent message to the patient. And a never event is a consultant saying something that they don't remember ever saying to the attending. That has to stop. So with that, I would just remind you that children are just a third of the population, but they're 100% of the future. And that is such a noble responsibility that all of us have in this room. We take care of the future of this great nation. So thank you.
Thanks for teaching
Okay.
us. Yeah. So I noticed that the second author on the first Chris Forrest paper is one of these legendary Utah pediatricians, Gordon Glade, from Pediatric Research and Office Settings in American Forks. So that was cool to
Oh,
see
good.
that
Great.
doctor on there. And then my question is about contrast. Could you contrast like the success of small, community pediatric units compared to the bigger systems? Because even though we're small, we are big.
Yeah.
On the ease or success of communicating with the community
Yeah.
pediatricians?
Yeah, I mean, there's no doubt in very small communities where there's just a few subspecialists and a few people doing primary care that they kind of just set up the workflow themselves. We obviously have challenges because we're a really big system, but that's also a blessing. We have the ability to tap into things that Intermountain Health and U Health have. And again, I'm really hot on getting care coordination more involved with us. I'm really excited about our conversion on Saturday to Epic and the tools that electronic platform will allow us to have to customize things a little bit and to get better. So we have some unique challenges because we're big, but I think those challenges come with, one, because we're big, we have a plethora of specialists that a small community would not have access to. I mean, there's almost no problems I can think of that we don't have somebody that knows something about that. So that's a real privilege to be in a community that has that depth of expertise. And we have access to some really good kind of infrastructure that we just have to help manage so that it does the good things for kids. That's how I'd answer that. Okay, well, start thinking about who wants to work on this. I'm going to be reaching out in a couple weeks after I talk with my partners. I see Ryan and Seth here. Like, we're going to need to do this in a formal way. The good news is it's at Intermountain, it's like strategy deployment season, which is goal setting. So we're going to do strategy deployment, and I want to make sure that this is one of the goals that we work on. And then we'll do this in a formal way, and we'll come up with ways of getting people some time to do this, and we'll keep a focus on it. So expect to hear from me in the next couple weeks. So thank you, Miguel.
Thanks everybody. Thanks for teaching us. And the credit code is 40527. And yeah, I'm excited for everyone to be communicating and have the one plan and in a lot better way. So appreciate it.
Sometimes there's no one else who loves me like you used to. Sometimes we're not ourselves. There's no one I can